This is a interpartum podcast for Nursing 242. So first thing we're going to talk about is preterm labor. So remember, preterm labor is going to occur prior to 37 weeks of gestation. And there's a difference between preterm labor and preterm contractions. Many women will have preterm contractions where they'll actually feel contractions, but it's not preterm labor because the definition of preterm labor is when you have cervical change, okay? So if the woman is just contracting but not having cervical change, it's preterm contractions. But if the cervix is changing, it's preterm labor. A significant amount of risk factors for preterm labor, although it can happen to someone who has no risk factors. So some of the things that we know can increase a woman's risk. Significant stress in her life. So that could be physical stress, emotional stress, domestic violence, infections. Any type of infection increases a woman's risk of preterm labor. So that could be sexually transmitted infections, the flu, urinary tract infections, any of those can cause it. A previous history of preterm labor or birth in a previous pregnancy increases the risk in a subsequent pregnancy. Carrying multiples is also going to increase the woman's risk of preterm labor as well. So these are just some of the potential risks for preterm labor or preterm birth. So for evaluation, the big thing is to determine, are these just preterm contractions or preterm labor? So obviously a vaginal exam or an ultrasound where we're measuring the length of the cervix, those are going to be two options to determine whether or not we're having cervical change. Other evaluations that would be done, obviously continuous electronic fetal monitoring to assess how the baby's doing and to also monitor the contraction pattern can be helpful. We usually look for any signs of infection that could have potentially caused the preterm labor. So we might be checking a woman's urinalysis to see if there's any type of bladder infection, for instance, because that's a common occurrence in pregnant women. Other evaluations that might be done, we might do an ultrasound, like I said, not just to measure the length of the cervix, but to assess the overall fetal well-being, looking at growth, fluid, the placenta, making sure there's no other cause. Another screening test that we can do for preterm labor is something called a fetal fibronectin test, which we talked about briefly back in antepartum care. So a fetal fibronectin test is going to be a swab that's done taken from right back behind the cervix. So the healthcare provider would put a sterile speculum in the vagina, take a swab from back behind the cervix, and process it. And we're looking for a substance called fetal fibronectin. So when the fetal fibronectin is present, it tells us what we already know, that the woman is at a higher risk to have a preterm delivery. When the fetal fibronectin test is negative, it has a pretty high predictive value of telling us that it's very unlikely that this woman will deliver her baby in the next 2 to 4 weeks. Now, you can't do this fetal fibronectin test if the patient has had any vaginal bleeding in the last 24 to 48 hours, or if she's had intercourse or any type of internal vaginal exam in the last 24 hours. So as nurses, we need to be mindful when we're checking a patient in who might potentially be in preterm labor or be at risk for it, not to do an exam until we know whether or not the provider wants to collect the fetal fibronectin swab, because that should be done as the very first thing before we do a digital vaginal exam to determine if there's dilation or not. Nursing management and treatment. So medications we're going to talk about in just a minute. We'll do things like hydrate the patient, whether that be PO hydration or IV hydration, because dehydration can also be a cause of preterm contractions. So we want to make sure the patient's well hydrated. We might give medications to help stop contractions. And we want to encourage the patient to rest as well to try to decrease any contractions that may be occurring. And then certainly if it's determined she's not currently in preterm labor, but maybe is at risk, we may want to consider talking to her about some lifestyle modifications when she goes home. So decreasing physical activity, stress, perhaps putting her on pelvic rest if she's at a risk for preterm labor or preterm birth. Medications to treat preterm labor. So there are quite a few that we can use, although many of these are not FDA approved for the reason we use them in the obstetric patient. So we've talked before about magnesium sulfate when we talked about preeclampsia. So we know magnesium sulfate helps relax the uterus, right? It's a smooth muscle relaxant. So it can help stop contractions. We also give it for what we call fetal neuroprotection. So giving magnesium to a woman who's at high risk for a preterm birth, so a woman who comes in, is having cervical change, contracting, we think there's a chance she might deliver. We give her the magnesium to hopefully slow the labor down, but we also give it for fetal neuroprotection. So it's going to offer the fetus some protection when they're born prematurely, because premature fetuses we know are at risk for respiratory issues, but they're also at risk for a lot of neurological issues, bleeds in the brain, and other complications due to their prematurity. So your monitoring and care on magnesium sulfate is going to be very similar as it was for your preeclamptic patient. So you're still going to do all of the same assessments. You're going to be monitoring deep tendon reflexes because that's going to tell you if there's toxicity. You're going to be watching urinary output, paying attention to both mom and baby, continuous electronic fetal monitoring, frequent vital signs, eyes and O's, all of those same things. Other medications that we can use to treat preterm labor. Now, when you understand the mechanism of action for all of these meds, it should help you understand why we never give them together. So between our three tocolytics here, magnesium, nifedipine, and terbutaline, you would only give one of these at a time. You wouldn't stack these meds and give them together because of the potential for significant harm to your patient. So for instance, if you combine mag sulfate and nifedipine together, well, we know what happens when you take magnesium, right? Your magnesium levels go up, your calcium levels go down. Think about what nifedipine is. Nifedipine is a calcium channel blocker. If you gave magnesium and nifedipine together, there's a good chance you could potentially cause cardiovascular collapse in your patient. You could kill her. So we don't ever give them concurrently. If, for instance, we had a patient on magnesium and she was on it for 24, 48 hours, things slowed down, we got steroids in her, which we'll talk about in a second, and we want to transition her to an oral medication to go home on, like nifedipine, then we would stop the magnesium. Most hospitals have a protocol for how many hours you need to wait before then you could start one of the oral agents, okay? So nifedipine we know is also called Procardia, calcium channel blocker. A lot of you might be familiar with it, giving it to your med-surg patients for hypertension. Well, it's also a smooth muscle relaxant, so it helps relax the uterus. Nifedipine is nice because patients can take it at home. They don't need to be in the hospital to take it, and there's very little side effects. The things we worry about obviously are hypotension. So if you have a patient who already has blood pressure that's on the lower end of the normal range, you want to talk to her about signs of hypotension and how to take the medication appropriately and the things to be mindful of for safety. So like making sure you tell her, like in the middle of the night, especially when she gets up to void, to make sure she sits and dangles her feet on the side of the bed for a few minutes before she stands up and ambulates to the bathroom. Nifedipine can also cause facial flushing within 30 minutes of the patient taking it, and that can be cause for concern in a patient who's not aware of that. So making sure you explain that and they know that it's a normal side effect so that they don't worry that potentially they're having some type of adverse reaction to the medication. Nifedipine has no known fetal side effects, so as far as we know, it's a very safe way to help treat preterm contractions and prevent preterm labor once the patient goes home. Terbutaline is another medication that isn't used as much as it used to be because we have better medications now like nifedipine with less side effects. But occasionally we will still use terbutaline on a patient if it's necessary. Terbutaline, if some of you might be familiar, it's also a medication that's used to treat asthma. It's a bronchodilator. So think about bronchodilators and some of the side effects of them. Increased heart rate, right? That's a common side effect with bronchodilators. So when we give a patient terbutaline, there's a good chance it's going to increase the maternal heart rate, which it could then also increase the fetal heart rate. Terbutaline can be given by mouth. It can also be given sub-Q. And we used to administer it to patients. They would actually have a pump similar to like an insulin pump. That has kind of fallen out of favor because nifedipine is more preferred as a long-term maintenance medication once the patient goes home over terbutaline. So if we utilize terbutaline, we need to be aware that when we give it, a normal reaction is going to be tachycardia in the mother, so the mother should be educated about that. And because it is a bronchodilator, there is a potential for the patient to develop pulmonary edema. So we have to be really mindful that if we're PO or IV hydrating the patient, and that's not working, and then we move to giving her terbutaline, we have to be really cautious and careful about the risk of pulmonary edema. So being mindful of that. So those are our 3 tocolytic medications. Some other medications that we might give when a patient has preterm labor or preterm contractions might be prostaglandin inhibitors. So we think that prostaglandins are one of the hormones that are responsible for the initiation of labor. So if we give a medication that's going to inhibit the release of those prostaglandins, then the thought is that's going to help stop any preterm labor that might be occurring. So the prostaglandin inhibitor that we give in obstetrics is Indocin or indomethacin. And it can be given by mouth. It can also be given vaginally, or it can be given rectally as a suppository as well. So there's a narrow window of time to give indomethacin because there's a chance that it could cause premature closure of the ductus arteriosus in the fetal heart. So typically it's not given past the 34-week mark of gestation. Antibiotics are another medication we might give. So when a patient's admitted in preterm labor and we're not really quite sure, we're waiting maybe for culture results to come back to see if there's any infection, we might give a broad spectrum antibiotic as a thought of it could kill any infection the patient might have. And it's also going to be used for prevention of group beta strep, which we're going to talk about here in a few more slides, because in the preterm patient, we typically don't know what their group beta strep status is, so we treat them as if they were positive since we don't know the result. One of the main goals of tocolytic treatment is to get corticosteroids on board. So betamethasone or Celestone is the one that we use primarily in obstetrics. Dexamethasone can also be given when we experience a shortage of betamethasone. Betamethasone is given as an IM injection, and the patient gets 2 doses 24 hours apart. So she'll get a dose, 24 hours later we give the second dose. The whole purpose of betamethasone is to help boost fetal lung maturity. So this can be given really all the way up to 37 weeks. And there's even some literature that says even at 37 weeks it may still be beneficial, even though that's not typically considered preterm anymore, but even 37-weekers might struggle to not have complete lung development. So betamethasone, corticosteroid given as an injection to the mother to help boost fetal lung maturity. So it's going to have a lot of the similar side effects of any other corticosteroid you would administer to your patient. Has the potential to increase mom's risk of infection and can cause hyperglycemia in the mother. So if this is a patient especially that you know is a diabetic, then we need to be aware that when we give her these doses that we may see a significant elevation in her blood sugar for several days after administration of the medication. Premature rupture of membranes is another complication that can occur. So there's a couple of different terms that you need to understand the difference of. So premature rupture of membranes, or PROM, P-R-O-M, all this means is that the membranes have ruptured prior to the onset of labor. So you have a patient who's not in labor and her water broke. And this is for patients who are 37 weeks pregnant or more. So it's actually a term patient. So when we use the term premature, we just mean that the water breaks prematurely, so prior to the onset of labor. Then we have what we call PPROM, so preterm premature rupture of membranes. So that's when the water breaks prior to the onset of labor in a patient who is less than 37 weeks of gestation. And then prolonged rupture of membranes is when the membranes have been ruptured for more than 24 hours before a patient gives birth. Now, the longer a woman's water is broken, the higher of a risk there is for infection for both her and her baby. So we're mostly worried about infection in all of these scenarios. When the term patient has her water break prior to the onset of labor, usually there's some time given, 12, maybe even 24 hours, to see if labor will start spontaneously on its own. And for a lot of women, it will. But for some women, it won't. So in that situation, their labor might need to be induced or augmented to help decrease their risk of infection. When you have a patient whose water is broken, we know that clock starts ticking for infection. So we need to be mindful of anything else that could increase her risk of infection. So making sure that vaginal examinations are limited, catheterizations are limited, the use of internal monitoring is limited unless it's absolutely necessary. When we have a patient who has preterm premature rupture of membranes, how she's managed depends on a lot of things. Depends on the gestational age. Usually the rule of thumb in evidence-based practice tells us that if the patient is 34 to 35 weeks or above, then typically we can let them deliver. But if they're less than 34 weeks of gestation, then usually we're going to expectantly manage them, meaning we're going to just watch them very closely for signs of infection. We're going to monitor the fetal heart rate continuously, monitor contractions, monitor, all those signs of potential infection, but give the baby a little more time in utero to mature, knowing that if we start to see any sign of infection in mom or baby, that we would intervene and work towards delivery in those situations, because the risk of infection would be higher than the benefit of allowing the lungs to mature a little bit further. And remember, we're worried about that risk of chorioamnionitis. Many of you know about that through previous lectures and also from some of the ATI modules that you have been doing for your clinical assignments. So when a patient develops chorioamnionitis, so that infection essentially within the amniotic sac, we're worried not only about mom, but we're worried about sepsis in the newborn. And the woman would also be at a really high risk for a postpartum hemorrhage as well, because that infected uterus would have difficulty contracting. Okay, so group beta strep. This was, if you remember back to the antepartum lecture, this is one of the infections that we screen for in pregnancy, okay? All women should be screened during pregnancy somewhere between 35 to 37 weeks, but current literature is really telling us we should hold off and screen between 36 and 37 weeks and not do it so far out as 35 weeks. So group B strep, remember, is a bacteria about 30-ish% of women have in their reproductive tracts. The bacteria is typically not harmful to a woman, but it can be harmful to the baby if the baby actually gets infected with the bacteria during the labor and birth process. So this is how we kind of determine who needs treatment in labor and who does not, okay? So women who should be treated for group B strep or unknown group B strep, these would be the scenarios. If she previously gave birth to an infant who had invasive GBS disease, meaning a kid that basically got GBS sepsis, because that tells us she was probably highly colonized. And even if we test her this pregnancy and it's negative, there's still a high potential that she's carrier of the bacteria, because this bacteria can be transient. It can come and go in some women. So you might screen them at one point and then 2-3 weeks later, the bacteria could be present again. If they've had a positive group B strep screening culture during the current pregnancy, if it's a scheduled C-section and their water doesn't break, they don't need antibiotics because there's really no exposure to the fetus in those situations. For patients who come in and their GBS status is unknown, so either the results are pending, that they're too early, or the lab lost it, whatever the reason, if we would treat them if they were less than 37 weeks. So if they're preterm, we would treat them if the culture results were unknown. If their water was broken for more than 18 hours and the culture results were unknown, we would treat them. And if they run a fever of greater than 100.4 in labor, we would treat them. Okay, the women who do not need to be treated. So women who we know were negative in this pregnancy, but maybe they were positive in a previous pregnancy. If they have a scheduled planned C-section and their water is not broken, or if they've had negative cultures during the pregnancy, even if they have some of these intrapartum risk factors. So ideally, penicillin is the drug of choice for patients. They get a 5 million unit loading dose and then usually 3 million units every 4 hours until they deliver. If penicillin is not available because we have experienced shortages before, we can give ampicillin instead. Now, for your patients who are allergic to penicillin, we kind of sort them out based on their risk of reaction. So like do they have a history of anaphylaxis, or do they have a low risk possibility of an allergic reaction to penicillin? You know, like the patients who tell us, oh, you know, when I take oral penicillin, it gives me diarrhea or vomiting. Those would be considered more low risk, but the high risk patients would be anybody who's previously had anaphylaxis, they've had hives or shortness of breath or anything like that after taking penicillin. So based on that, we would give them other medications like cefazolin or perhaps clindamycin or vancomycin, depending on their risk category. Okay, trauma in pregnancy. So trauma can occur for lots of different reasons, right? The patient might fall, she might be in a car accident, she might be a victim of domestic violence. I've seen all kinds of things. Nurses, you know, sometimes you're taking care of, let's say, individuals maybe on the mental health unit or with developmental delays who accidentally kick or punch someone as they're being taken down in a clinical situation. So lots of options for trauma in pregnancy. So of course we're worried about abruption. If you go back to the domestic violence lecture, that's the thing we're most worried about with trauma. Like, will we end up with a placental abruption? Is there any kind of damage to the fetus in utero? So we're worried about abruption, and we're also worried about that woman who's Rh negative too. You know, is there that potential that this patient might need RhoGAM depending on her blood type? So when a patient has trauma in pregnancy, especially if they're later in the second trimester or in the third trimester, there's more of a risk to the fetus. A woman who's first trimester and has trauma, you know, typically the fetus at that point is so well cushioned, it's going to be okay. It's when pregnancy is more advanced, we're worried. So things we would do. Typically, we monitor a patient in the hospital for 4 hours after trauma as the bare minimum. Certainly, if she's had significant trauma and has medical needs because of that, that would be different. But like, for instance, the patient who slips and falls on a patch of ice. No broken bones, no bruising, but she fell. So those are the patients that are cleared medically, but we need to watch her from an obstetric standpoint. So typically 4 hours of continuous electronic fetal monitoring. We also do an ultrasound to look at the placenta to make sure that there's no visual evidence of an abruption. And then we would also do blood work. So if the patient's Rh negative, we're going to prepare RhoGAM for her if necessary. And we're also going to do a test called a Kleinhauer-Becky, or it's also called a fetal hemoglobin. And what that's going to tell us is, are there any fetal cells circulating in the maternal bloodstream? If that occurs, then that tells us that there has been some type of mixing of blood between mom and baby, and essentially there could be a very small abruption that we might not see on ultrasound. Okay, so these women, we need to monitor them. If all of their testing is negative and normal and they go home, then we need to talk to them about danger signs going forward. You know, so being aware of painful contractions, decreased fetal movement, anything that could potentially mimic an abruption. Okay, macrosomia. So we've talked a little bit before about macrosomia, or babies that are large for gestational age. So this is going to be when the weight of the fetus is greater than 4,500 grams, okay? We know that more likely to see this in a woman who has diabetes, a woman who has a previous history of giving birth to a macrosomic infant, and also in women who are obese. Certainly you can have none of those risk factors and still have a macrosomic infant. Okay, clinical presentation and things that we're concerned about when we have an infant or a fetus that is potentially macrosomic. We're worried about fit. We're worried about, you know, injury at delivery. So will we be able to have a vaginal birth, or should the patient be offered a C-section depending on how big we assume the baby is? And then at the time of delivery, we're going to be worried about fetal injury and conditions like shoulder dystocia, which we're going to talk about here in just a minute. And then, of course, post-delivery with the baby, we're going to be worried about blood sugar, the baby being able to maintain their sugars. CPD, or cephalopelvic disproportion. So what that basically means in a nutshell is the baby's head can't fit through the pelvis, okay? And I mean, it can also be the buttocks if the baby's presenting breech, but for all intents and purposes, if we're allowing a patient to labor, they should be head down. So with CPD, what that means is whatever way the baby is positioned is in a position where that portion of the head can't fit through the maternal pelvis. Okay, you can't always predict CPD. It's not always macrosomic infants that don't fit. Sometimes it can be a normal sized or even a small for gestation infant, but perhaps the way the baby is positioned or the way the head is making it difficult for it to pass through the pelvis. So, if the fetal head isn't flexed, like if the chin isn't flexed down to the chest, for instance, if the head is like kind of hyperextended back, that can make a bigger portion of the head trying to fit through the pelvis. If the baby is in that occiput posterior position, so facing up instead of facing down, when they come that way, a larger diameter of the head is trying to fit through the pelvis when they're positioned in that way and can make it more difficult for the baby to be born. If there truly is CPD, which you can't always predict ahead of time, then the patient is going to need to have a C-section because that baby is not going to fit through mom's pelvis. Okay, dystocia. So there's a couple of different ways we talk about dystocia in labor. So it can be with power, passenger, or passage. So power is when the uterine contractions and mom's forces are not strong enough to expel the baby. The passenger, so is kind of like what we just talked about, can be the fetal size, position, or presentation. So maybe the baby is facing up and the head is like flexed in the wrong way, so it's making it difficult for the baby to fit through, where if the baby were OA, facing down like it's supposed to be, and the chin was tucked to the chest, it would have fit normally. So sometimes the passenger or the fetus can be the cause of the dystocia. And then sometimes it's the passageway. It can be mom's pelvis or soft tissues that make it difficult for delivery to occur. Okay, so with power, it can be because contractions aren't strong enough. Maybe they're not coming frequently enough or not strong enough when they occur, or maybe like in an abruption pattern, we have tachysystole where the contractions are happening one after another, but they're not very strong contractions. So we need to make sure that we're laying hands on the patient, we're actually palpating her abdomen, feeling how strong her contractions are, asking the patient what she's feeling. Now, certainly if she has epidural anesthesia, she's not going to be able to really describe that to us. So we would have to palpate the abdomen ourselves to really feel that and know what's going on with her. In some instances, the patient may need medications like oxytocin to help get those contractions a little bit stronger, to give us a little bit more power behind them. So we might have dystocia because of the passenger, okay? So this can be for reasons like the baby's sort of malpresenting, can be facing up instead of facing down, can be a face or a brow presentation, a breech presentation, a shoulder presentation, lots of different potential ways that the baby could present in the wrong manner, okay? So in those cases, if we have a presentation other than a normal vertex, a head down presentation, then the patient would need to have a C-section in those situations. We don't typically deliver breech babies vaginally. It can be done. It's usually a risk versus benefit situation. And if you watch the video that I have loaded for this week, it'll kind of go through the different presentations and give you examples and let you see what a breech delivery looks like and why we really encourage those moms to have C-sections because of the potential risk to the fetus. Other presentations like brow or face presentations, in those situations we're obviously worried that the baby will get impacted on the way out and be stuck. So we're worried about, part of the baby delivering and not a complete delivery, which could be a life-threatening emergency for the baby. So here's an example of a face presentation. So you have a larger portion of the baby that's trying to come out versus the smaller portion of the back of the fetal head. Babies can be born in this position, but it is much more difficult, and usually it's kind of accidentally that we find this as the patient is rapidly delivering, that their malpresentation is there versus a normal vertex head down presentation. So let's go back one more slide here for a minute. Another thing we need to be mindful of with the passenger and the passageway is that risk for shoulder dystocia. So there's a video loaded about shoulder dystocia as well for this week that you guys can watch. Shoulder dystocia is when the fetal head delivers, but then the shoulders are impacted in the maternal pelvis. Shoulder dystocia is a life-threatening emergency for the fetus because there's a very narrow window of time to safely get the baby out before the baby starts to become deprived of oxygenation. We also need to be very, very careful and mindful that the delivering provider isn't using excessive force or traction on the fetal head to try to deliver the shoulders, because in those situations, then we run a risk of damage and injury to the fetus, especially what we call a brachial plexus injury. So it can essentially damage the nerves running through the neck down into the arms and the shoulder, which can cause partial or complete paralysis in that limb in that baby. So shoulder dystocia is a life-threatening emergency for the fetus, and the video clip that I have posted is going to show you a little bit better the maneuvers and some of the nursing care that is needed during a dystocia. So as nurses, we're going to be helping position the patient, keeping track of the time frame that it's taking for different maneuvers to attempt to deliver the baby safely, and then of course being ready to resuscitate the baby after delivery. We've talked a little bit before about amniotic fluid. So we have two extremes. We have hydramnios or polyhydramnios. So that's when we have an excessive amount of amniotic fluid. And the uterus can become overdistended, overstretched. And we've talked before about how that can set up the mom for risk of a postpartum hemorrhage. It can also increase the risk of preterm labor as well because the uterus is overstretched and overdistended. There can be a multitude of reasons of why polyhydramnios can occur. Diabetes is typically the most common reason. You can also see it sometimes if there are certain congenital anomalies in the fetus, but polyhydramnios can be present in the absence of risk factors. So you can have a normal healthy mom, a normal healthy baby, and mom has polyhydramnios. So it can happen just randomly on its own. Oligohydramnios is the other side of the spectrum, okay? With oligohydramnios, we have a less than normal amount of amniotic fluid, and that number is really dependent on the gestational age of the fetus, okay? The expected amount of fluid starts to decrease as pregnancy increases, so it really depends on the gestational age what's considered abnormal. So when we have oligohydramnios, some causes of that can be if maybe the mom has ruptured membranes and doesn't know it. We can also see it if there are any type of urinary tract or renal issues in the fetus in utero. We can also see it as a patient becomes overdue or past their due date. If you have a poorly functioning placenta, it can decrease perfusion, which can also affect the amount of amniotic fluid surrounding the fetus. Amniotic fluid is really important because the fetus actually in utero will actually swallow it and essentially pee it back out. And it's very crucial to fetal lung development. They're supposed to live in that nice, big, fluid-filled environment, and that helps with lung development. So when we have low amounts of fluid, we're worried about lung development, and then we're also worried about the potential for what we call a cord accident, that the umbilical cord could potentially get compressed because of the lack of fluid or cushion surrounding mom and baby. So typically, if oligohydramnios is present, if the patient is anywhere near term, the recommendation is delivery. For the preterm patient, they might be might be admitted and observed very closely, given IV fluids, and an attempt to try to hopefully rehydrate mom, which might help with baby, and then follow her very closely. Other complications that we briefly touched upon when we talked about postpartum hemorrhage were abnormal implantation of the placenta. So this goes way beyond placenta previas. Now we're talking about accretas. So there's several different kinds. There's placenta accreta, and you can see all the different sort of pictures here to kind of give you a visual idea of what's happening. So placenta accreta is where the placenta attaches directly to the myometrium but does not invade itself through the myometrium. And that's the one that's a little more common. A placenta increta will actually invade itself into the myometrium layer. And a placenta percreta is the most dangerous and worrisome because it actually perforates itself through the wall of the uterus and can potentially attach itself to adjacent organs in mom's pelvis or abdomen. Okay, some risk factors for accretas: advanced maternal age, so women who are over the age of 35, women who have had a previous surgery on their uterus, so previous C-sections. Women who smoke are also going to be at a higher risk. And when a placenta previa is present, there's also a higher risk that the previa could also be an accreta as well. Depending on the severity of attachment depends on the management of the patient. Hopefully it's been diagnosed in utero and there's knowledge of it pre-delivery, because if there's any type of accreta, increta, or percreta, the patient needs to be delivered via C-section. And in the cases of increta or percretas, the patient is likely going to end up with a hysterectomy as well. Prolapse umbilical cord. So that is when the cord is going to precede the fetal presenting part. So the cord comes out in front of hopefully the fetal head, but if there's a breech presentation, it could prolapse in front of the breech presentation as well. This can happen when the water breaks. Women who have polyhydramnios, so an excessive amount of fluid, you're more likely to see a prolapsed cord when their water breaks because of the large amount of amniotic fluid that could potentially start rushing out. Usually, if you don't visually see it, you can kind of know or be on alert that this is potentially happening. So for instance, if the water breaks and the heart rate suddenly tanks and gets really low, that can be because the umbilical cord has come out in front of the presenting part. And what happens is then that presenting part is going to compress or put pressure on the cord and is going to decrease the blood and oxygen flow to the baby. It is a life-threatening emergency for the fetus when it happens. So our role as nurses, when this happens, obviously you need to immediately make sure that you call for help as you're starting to offer assistance to the patient. You want to take your sterile gloved hand and you're going to, without touching the cord, you want to try as hard as you can not to touch or manipulate the cord, because every time we touch it, it's going to cause some vasospasm in the cord, which is going to further complicate the issue. So you're going to take that sterile gloved hand and you're going to, lack of a nicer term, shove the fetal head or butt, whatever the presenting part is, as high as you can in the uterus and get all the pressure off of the cord. Okay. You can also, if you can, put the patient in Trendelenburg to help offer a little more relief of that pressure as well. For those of you potentially my paramedics and EMTs, if you're out in the field and you find a patient with this, sometimes what we do is we'll tell you to put them on all fours, but then have her head down so that her backside is sticking up in the air, but her abdomen is slanted downwards to try to get the pressure off of the cord. This patient will need an immediate C-section, and your hand stays in there alleviating that pressure until the C-section is at the point where the baby is lifted out of the uterus. Okay. An occult cord prolapse is a little bit different. That's where at the time of delivery you find that a loop of the cord is folded over like next to the fetal head or by the shoulder, but it's not a complete prolapse where it comes out in front of the presenting part. When we have babies who are in the breech presentation, sometimes we offer a patient what we call an external cephalic version or ECV. And this is offered in the attempt of preventing a cesarean delivery for patients who have breech babies. Okay. Now, not every patient with a breech baby is a candidate for an external cephalic version. If the fetus needs to be in the appropriate breech presentation. So when you guys watch the breech delivery video that I have posted, you'll see what the differences look like. But basically the breech in this picture here is what we call a complete breech, where the legs are crossed and tucked up. Complete breeches or frank breeches is where the fetal feet are up by the fetal ears. So both legs are flexed up. That would be another criteria, a patient that would be a candidate. But for babies that are what we call footling breech, where either 1 or 2 feet are presenting in the maternal pelvis, those babies are not going to be able to be turned. There's too much risk associated with it. So criteria is the breech presentation itself needs to be frank breech or a complete breech. The mother needs to have an adequate amount of amniotic fluid around the baby. She shouldn't have too much fluid or too little fluid. And she cannot have an anterior placenta, meaning the placenta can't be implanted in the front of the uterus. It needs to be implanted at the top or the back of the uterus. She also should not have a previous history of surgery on her uterus, so no previous C-sections, myomectomies, any type of surgeries on her uterus previously. When we offer an external cephalic version to a patient, typically they're around 36 weeks, give or take. You want to do it while we still have a little bit of room to potentially turn the baby, but you don't want to do it too early in the pregnancy because there's a chance the baby could still flip. So a patient's brought into the hospital, given an IV. We might give a medication like terbutaline to relax the uterus a little bit. And then the provider, under ultrasound guidance, will attempt externally to rotate the baby. I also have a video of this posted that you guys can also watch to kind of give you an example of what this looks like from a patient perspective. So after an external cephalic version, there's a chance the baby might not turn at all while we attempt it. There's a chance that we could be successful. The kid will turn, become head down, but then will flip back to a breech or some other presentation. And there's a chance that the procedure could cause fetal distress or could potentially put mom into labor. So C-sections, TOLACs, VBACs. So there's two terms that are used interchangeably and they really don't mean the same thing. When you have a patient who's had a previous C-section and would like to have a vaginal delivery and comes in labor, she's not a VBAC. She's not really technically a VBAC until she's had that vaginal birth after a previous cesarean. So a woman who comes in with a scar on her uterus wanting to labor, we call them TOLACs. So she's trying a trial of labor after a previous cesarean section. Now, there's really only one type of uterine incision that allows for a TOLAC, and that would be this top picture here where there's the low transverse incision on the uterus, because that carries the lowest risk of uterine rupture, okay? Higher risk for uterine rupture, patients who are not VBAC candidates. So patients who have a vertical or what we call a classical, that up and down incision on their uterus, or patients who have what we call a T incision on their uterus. So perhaps in a previous C-section, they attempted a low transverse, but for some reason they had to extend the opening, the incision upward to get the baby out. Those two patients in the below pictures are going to be at a much higher risk for uterine rupture. So what we're worried about when a patient comes in and is attempting that vaginal birth, we're worried that she's going to have a uterine rupture during the labor and birth process. Uterine rupture in the appropriately selected candidate is very unlikely to happen. It's like less than a 1% chance of it happening in that low risk appropriately selected candidate. So ideally we want a patient who maybe their previous C-section was for fetal distress or a malpresentation. Those women are going to be more likely to be successful in their attempt to have a vaginal birth. Women who previously had C-sections for CPD, for instance, or their labor stopped or stalled out, or the baby didn't seem to fit, so that's cephalopropelvic disproportion. those women are going to be a little less likely to be successful in having a vaginal birth. Our role as nurses, when a patient's attempting a vaginal birth after a previous C-section, even if, let's say, she had a C-section and then had a vaginal birth with her second baby and she's coming back this time, third baby, to have another vaginal birth, she's still considered a TOLAC and somebody who's attempting a VBAC because that scar on her uterus has not gone away. So we're going to monitor them very closely, both mom and baby, for signs of uterine rupture. So signs of uterine rupture can obviously in the mom be pain, it could be bleeding. If the patient has epidural anesthesia, she's not going to feel the pain over her abdomen if her uterus ruptures. A lot of times it's going to be referred pain. She may suddenly complain of chest or shoulder pain or pressure, and that could be a sign of uterine rupture. And then certainly fetal distress could also be a sign of uterine rupture. If the uterus ruptures, it's a life-threatening emergency for both mom and baby, and she will need an immediate C-section in an attempt to save the baby's life and to hopefully save mom's uterus. So there's a chance mom could lose her uterus as well. So C-sections, there are risks associated with C-sections, right? Mom's more likely to have more bleeding, to hemorrhage. There's risk to the surrounding organs during the surgery, a chance that we could damage bowel, bladder, other surrounding organs. There's a risk of infection. There's a risk of harm to the fetus when we're cutting into the uterus. And there are some potential risks for other pregnancies going forward. So C-sections should always be conducted where the benefits outweigh the risks. So, when we have a baby who potentially is in distress, when we have a baby who's in the wrong position, those are reasons that we should be doing cesarean sections, placenta previas, abruptions. We, women who want to have a C-section just to have one because maybe they're fearful of vaginal birth, those are women who should be counseled very appropriately about the risk of cesarean section. Women who have previously had a cesarean section should be given the option because a VBAC is not risk-free. So the patient should know the risks and the benefits of both a repeat cesarean section and VBAC, and there should be, open dialogue between her and her provider about what the safest method of delivery might be for both her and her baby so she can make an informed choice. Assisted deliveries with vacuum or forceps. So these are two options to assist the patient to have a vaginal birth. A vacuum is going to be more risky to the fetus, while forceps are going to be more risky for the mother. So vacuum assisted delivery, any type of assisted delivery, whether they be vacuum or forceps, should really only be done when the risks of the procedure are outweighed by the benefits of the procedure. So for instance, if maybe mom has become exhausted or there's a little bit of fetal distress and she's very, very close to delivering vaginally, and the time it would take to assist the baby from below, getting the baby out that way would be faster than perhaps taking her back and doing a C-section, might be a reason for an assisted delivery. So the patient should obviously be appropriately counseled by the provider. There's risk of injury to the fetus, both with a vacuum and forceps, bleeding, bruising, swelling. There's also a potential risk of skull fracture. So we want to make sure that the mother is aware of this. With a forceps assisted delivery, there's a risk of significant perineal trauma to the mother as well. And that is the end of our podcast for intrapartum risks.